Welcome, welcome, welcome. I'll go ahead and try to share the live. Oh, I think I did it wrong. How are you guys doing? Can you just go ahead and tap up the live for me? You can go ahead and share as well. Send the live out to one and two of your friends. Lux, welcome. Danilo, welcome. How are you? Oh, yeah, I'm doing okay. I'm doing okay. Just trying to share out this live so we can get some more purses over here. All right. They will eventually show up. Welcome on YT as well. Thank you, Sammy. How are you doing? My glasses clean. Who is on YT here? Who is on YouTube? If you don't mind, just go ahead and say hello. Island Girl Teresa, how are you? Try and get this thing up. So we have a very fun packed night, I'd say. So I had to cancel my UWorld. Well, they canceled it because I wanted to use another account. So we have questions tonight, but they're not from UWorld. So I'm waiting on my refund first. And then once I get it, then I will go ahead and reorder it on the new account. All right, so 7-Eleven. All right, let me just turn this thing around. Well, welcome. If you're new here, I'm Stacy. All right, I'm Stacy, originally from Jamaica, work as a nurse here in the States. And tonight we're going to be doing some questions. So go ahead and just, put your answers in the comment box below. Flip. Let me fix this up. Uh-oh, hold on. How are you guys on YT doing? I'm trying to do the setup. So you can go ahead and follow me on TikTok at ThinkNursing and on YT YouTube at ThinkNursing, one word. All right, we do study sessions on Tuesdays and Thursdays at 7 p.m. Central Standard Time. So feel free to join in on the live. We talk a lot about, nursing. So we answer a lot of nursing questions. Try to make it very interactive. So all you need to do is just try to save your patient. And that's all we're going to be doing today. And we talk a little bit more about it. So I'm going to turn so you can actually see the questions there. And then from there. Hi, praise that pray. I am doing good. Taylor, welcome. All right, so let me turn this around so you guys can see the question. And it's not only for nurses. You can hang around so you can hear how the patients are actually being managed or treated. So in the event that somebody, at least you have a little idea of what to expect or what the nurses will be doing. Mule, welcome. All right, so this is like a speed section. We're gonna be doing a little bit of a test run here. So I have, what kind of questions I have here? I have some multiple choice, nurse or not. So basically you're just gonna tell me whether or not this is something that is for the nurse or you delegate to someone else. And we can talk a little bit about it. I also have some management questions, so we can go ahead and see if the management is correct. If not, we try to fix it. And then from there. All right, can we get the live up to like about 1,000? Can we share the live a little bit? Tap the screen up to give the live a like. Thank you, Roy. Thank you so much for tuning in. Silence, Vincent. So these are some safety questions. Then we have some delegation question. And then from there, we can't start the live without, having a little bit of an extra motivation tonight. So thank you so much for tuning in. Remember to share the live as well to your friends or on your page. So somebody over there who probably needs an extra study partner, they can join in and answer a few questions. Ruggins, welcome, welcome, welcome. How are you doing? I see 18 persons here on YouTube. How are you guys doing? Welcome, welcome, welcome. We're just trying to get the live up. Do you have a problem with oh, all right. So I'll have you just go ahead and tap up the live on YT. That would be nice. Just like a little extra motivation. So we're at 600. Jorama, welcome, welcome. All right. Let's kick it off. So the first question, as I said, this is a nurse or not, basically delegation. Would you keep this patient as a nurse or would you delegate? So it's a safety question, so you'll just decide. A patient on heparin has bleeding gums. Who should check on them? Is this something for the nurse or you can delegate to someone else, such as your LPN or your UAP? Thank you so much, Taylor. Thank you. So far, yes, I am doing good. I'm hoping the other folks here are doing well as well. Carousel, welcome, welcome. RN, okay, nice. And as I said, this is going to be a speed run, so we'll try to run through these and then we try to do some of the select all that apply questions. I'll try to finish by 8:15. So we're doing 1 hour tonight. So let's go. So the patient on heparin has bleeding gums. Who should check on them? Definitely your RN. Where is my cursor? Okay. So yes, bleeding is basically a potential complication. So you need your RN to do the assessment on this patient. Let's move on to number 2. A stable client needs hourly vital signs post-appendectomy. Is this something for your registered nurse or for your UAP or LPN? Hi, TS Music. How are you doing? Nana says you're LPN. Do we have anybody else on YT or YouTube or TikTok here who says otherwise? 3 dots on a red car. Welcome, welcome. I haven't seen you in a long time. Jorama says you're LPN. Okay, so your UAP can also do this. So your stable patients, routine vital signs, you can delegate to your UAP, your LPN. All right, a patient with chest pain says it's getting worse. Thank you for the gift. Patient with chest pain says it's getting worse. Who will you assign that patient to? Is it your registered nurse or your LPN UAP? Nana says your RN. Diane, welcome. 3 dots on a red car says RN. Definitely, because with this patient, chest pain is always priority. So you need your RN to intervene and do the necessary, interventions basically. A patient needs transport to X-ray. They're alert and stable. Who will you assign? An RN, UAP, LPN, CNA, whichever options you choose. So this patient is stable and they're in need of transportations to X-ray. You can do your CNA. Okay, nice. You don't necessarily need an RN to do that. If the patient is unstable, then you will go ahead and transport that patient to X-ray. All right, so we already do that. Who sees this patient, the nurse or your LPN, your UAP? A diabetic patient who is sweating and shaky. So this patient is what? Hyperglycemic. So who will you have see this patient? Lead Innovations, welcome, welcome. RN, CK Smart, welcome. Okay, so your nurse, this patient is hypoglycemic, it's life-threatening, so your RN must act. So this RN is going to be acting. What are they going to be grabbing for this patient? What are you going to get for this patient? So this patient is sweaty and shaky. You diagnose as having hypoglycemia. What will you be giving this patient? So the patient is confused. Sugar, glucose, nice. Yes. So a patient wants help with ordering lunch. Who will do this? RN, CNA, UPA. Pretty straightforward. So we'll go with, anyone. No clinical judgment needed. So your UAP can assist with that. COPD client oxygenation is at 94. Well, it dropped from 94 to 88%. Who will go ahead and see this patient? RN, 3 dots on a red car. Ruggins, why are you yawning? Huh? How are you doing? So Nana says you're LPN. Rose says you're RN. So what is the normal COPD oxygen saturation we're looking for? What's the normal range for your O2 sat? For your COPDias? Sapphire, welcome. So anywhere between what? 88 to 92%. Yes, 3 dots on a red car. Leading Novation. So this patient COPD, the client's oxygenation drops from 94 to 88. Is that something that is very concerning? So this says the nurse, acute changes in respiratory status, high priority. It's normal for COPD, yes. But if the patient is always hanging out in like the 94% and you notice that they've drastically dropped all of a sudden, then that is something that you will definitely need to, evaluate for. Because it can be like, a spontaneous pneumothorax, anything like that. Because more than likely this patient has a history of smoking. You have assessed symptoms too. Yes. So assess the patients and the symptoms and then from there. A confused elderly client needs the bed alarm turned on. Is that something you can do as an RN or delegate to someone else? And thank you guys for tuning in. UAP, yes. All right, so the confused patient here, you don't need any specific training or anything. The UAP can apply safety devices that are non-restraints. When do we use restraints on these patients? Is that something that you always want to go ahead and use? Hi, Alex. Welcome, welcome, welcome. Yes, restraints are always last resort, never in a nursing home. Yeah, even in the hospital, restraints are, always last resort. So always find other things to help with making sure that the patient is safe. Hi, Dr. Lagwanas. Welcome. A newly trained UAP asks if they can feed a post-stroke patient with unilateral weakness. So would you delegate this patient or what are you going to be doing for this patient? Delegation, disaster. Okay. No. So this patient is going to be for the nurse because of the risk for aspiration. So you need to get your swallow evaluations first before anything. And just like when you're in the hospital, you might have your patients coming in with, stroke-like symptoms and the doctor might order certain things. They might not put this swallow evaluation there. Just remember that this patient is at risk for, aspiration. So you want to go ahead and document that you do your swallow evaluation or your swallow test first. And then you go about with doing everything else in terms of if they need to be medicated orally. So this patient is at risk for aspiration, so the RN must assess swallowing first. A stable patient on day 3 post-op needs ambulation assistance. Is this something for your nurse, your UAP, CNA? Who will you delegate this patient to? Oh, your combative patient, Dr. Lagwana. Okay. Your LPN, 3 dots on a red car. Nana LPN, nice. Okay. So your UAP, the patient is stable. And just remember with NCLEX, just look at the words that they're using. So whenever you see stable patient, unstable, then you know what is happening. So make sure you understand who is a stable patient and who is an unstable patient. So the stable patient, day 3 post-op needs ambulation assistance. Your UAP can assist with that patient. All right, so stable and routine ambulation is pretty okay for this patient or for your UAP. A patient has new onset confusion. What do we call new onset confusion in patients? New onset confusion, what is one of the most likely cause for these patients? So the nurse, yes, it's new onset. Altered mental status, yes. Okay, hypoxia, UTI. Caitlin, welcome. Linda, welcome. Hypoglycemia, delirium, lead innovation, yes. All right, so anything that is new onset, the nurse has to assess the initial assessment. So go ahead and do your, your neuro checks. So you go ahead and, evaluate this patient. A patient needs blood glucose check before lunch. Your RN, your UAP, or your CNA. Who can do this? Your UAP. Yes. This is just like, a given. Patients are doing their glucose check at home. Family members are doing it at home. There's nothing specific or, significant in terms of training that they need. So UAP can perform finger sticks if trained, or interpret the results. Patient on PCA pump says, I feel extra sleepy. What are you thinking in terms of your differential diagnosis? What is happening with this patient? You have a patient on a PCA pump and the patient is feeling extra sleepy. So yes, your nurse, so they're drowsy. What are you thinking is happening with this patient? Oversedated, overdose? Okay, so what medication will you be grabbing for this patient if you're thinking of an overdose? Blood pressure is low. Okay. Yes, Sabina. Yes. So if it's an opioid they're on and they're overdose, you're thinking Narcan is the antidote for that, naloxone. Foxy B, welcome. Dr. Laguanas, yes, you're naloxone. Double check the dose as well. User 568, thank you for that. So always double check to make sure that the patient is not getting too much. So yes, the nurse will definitely need to take this patient and assess for possible overdose on the patient. Stable patient asks for a warm blanket is a given. So we're gonna say the UAP comfort measures are appropriate to delegate. Don't need any special training or anything like that. Unless this patient, is having a fever and the temperature is 104, 5, 6. The patient is hot, and then, you definitely probably would have to say to your UAP, hey, hold off on the, the blanket for a little bit. But there's nothing really in terms of with comfort measures that you need to delegate to anyone specific. A patient with a fresh post-op abdominal dressing is bleeding through. Who will you delegate this patient to? Thank you, guys. Remember to go ahead and tap up the live and share the live in the meantime. That would be nice. And the full length of the live stream will be posted on, will be on YouTube at ThinkNursing. So just in case you want to go through the questions again, they're all going to be on YouTube at ThinkNursing, where you can watch them at your own convenience. Nayeli, welcome. Yes, you're RN. So you have a patient that is post-op. Abdominal, dressing is bleeding through. You're thinking that this patient is having a hemorrhage. Incision probably open, yes. So think of, the post-op hemorrhage. That is going to be an emergency. So you need to keep an eye on this patient. So you have a patient that has, is a post-op. What kind of shock are they at risk for? So you have a patient that is post-op, abdominal, they had a lap, whatever procedure they had. What kind of shock are they at risk for with that hemorrhage? Carousel, hypovolemic shock. Hemorrhagic shock. Hypovolemic shock. Yes, Sani, hypovolemic shock. Peritoneal. Nurse T32, peritoneal. I don't know where to plug that in. But hypovolemic shock is what I'm looking for. Because they're losing the volume, all right? They're losing blood, so they're going to be at risk for low volume hypovolemic shock. So a patient is requesting discharge instructions. This is something that you can delegate to your UAP, your LPN, or your RN. Who will see this patient? Hi, Nissi, welcome. 3 dots on a red car, RN. Nissi, RN, yes. So this patient is going home. So even though the patient is stable, being discharged home, it is going to be your primary responsibility as the RN to go ahead and do your teaching. So anything that has to do with assessment, initial, first, basically, which other one? Your initial or educating, that is going to be for your RN. Meg is saying RN, LPN cannot educate only. LPN cannot educate, only reinforce education. Yes. Thank you for that, Nurse T32. So this patient is going to be for the nurse. Teaching cannot be delegated to anyone else. As I say, you reinforce to your LPN. Changing a colostomy bag on a stable patient. Who will take care of this patient? You have a stable patient. Who will take care of this colostomy bag here? I know nobody wants it, but the LPN, UAP, okay. So your UAP, if it is established and stable, can take care of this colostomy bag. And you order for IV morphine. Who will see this patient? Your RN. Okay, so IV. Not something that your LPN can do. So collecting urine sample from so your nurse will do that one. Collecting urine sample from a Foley catheter port. Nana says LPN, RN, and LPN. LPN can collect the sample or the UAP. Nice, yes. Hold on there. So collecting the urine sample from a Foley catheter port. All right, so this one we have here, nurse, UAP, okay. LPN can do RN. Okay. Why you say RN, Carousel? UAP. Your LPN can do it. Clean catch. Okay, collecting urine sample from the Foley catheter port. Oh, from the Foley catheter. If it is from the port, so if it is from the port, I thought that the sterile part. That's the part I'm thinking about. If it's from the port, then the RN has to do it. And then if it is from the bag, then your UAP can do it. Well, anybody can do it from the bag. But if it's going to be from that port where you have to maintain, the highest level of sterility there, port can do RN. Okay, Rose. So because of the increased risk for CNA, so if it's coming from the port, of that port for the Foley catheter, we're seeing where it makes sense because of the increase, in terms of sterility there. So I'm going to go with, the nurse here. I know a lot of us were saying the UAP, but then just to think of it. Thank you for the gift. Too sweet. Welcome, welcome, welcome. Nana says LPN. So if it is coming from the tubing, then the LPN, the CNA can do it. But if it is coming from the, the port itself, of that top there, of the catheter itself, then the RN will have to do that. UAP only can do it from the bag only. Okay. Thank you for that, Nurse T32. Turning a patient every 2 hourly. Who can do that one? So the questions might sound simple, but then when you think of it, a lot of things we're doing sometimes and we don't really think about the rationale because it might sound so simple, but then just look at the fact that they added port. So that makes a big difference in the answer itself. The CNA, turning the patient. Okay, so the UAP can do that one. If the stable patient, yes. Definitely, Hattie. Welcome. Mansoor, how are you doing? Okay, so those were some very quick questions. We'll go on to these questions here. Multiple choice question. A patient with acute pancreatitis suddenly develops a rigid board-like abdomen. What should the nurse suspect? A, gastric ulcer, internal hemorrhage, peritonitis, small bowel obstruction. So a patient with acute pancreatitis suddenly develops a rigid board abdomen. What's so CCC, peritonitis. Is that a surgical emergency? What is that? Is that an emergency or is something that we can always just hang around and say, okay, we'll treat and then from there? Hi, welcome, my little California girl. How are you doing? So emergency. So is this patient going to be NPO? Or we'll be feeding this patient? Surgical emergency. NPO the patient, definitely. Good. What are some things you can get for this patient in terms of the pre-op? So the doctor, you suspect that this patient is having peritonitis. What can you do in the meantime for the patient? I know we say NPO IV. What else can we be doing for this patient in terms of preparation for the OR? So my little California is saying D, small bowel obstruction. So it's C, because of the rigid board-like abdomen, that is more consistent with peritonitis. IV fluids. Well, we won't be giving the antibiotics as yet, carousel. So we're going to try to see what we can do in the meantime in terms of your management. So you're at the bedside and you suspect that this patient has peritonitis and you know that the doctor is going to be coming in the next 15 minutes. What can you do for the patient? So if they have pain medications, you go ahead and give that in the meantime. Talk about your IV. You have the patient NPO. You talk about your fluids. Would we think about getting any blood for this patient? You can get your consent forms. Yes, Anna Garcia can get your consent forms. All right, try to get your consent for your blood. Go in, cross match, get your samples for your type and screen. So all of those are things you'd want to go ahead and get in the meantime. Nice. So the answer is peritonitis. A hard rigid abdomen, worsening pain is a red flag for peritonitis due to leaking pancreatic enzymes. It signals acute deterioration and possible shock. So you want to get this patient to the OR as quick as possible and get, this patient procedure done. A patient on PCA, morphine, becomes extremely drowsy with respiratory rate of 6 breaths per minute. What is the nurse's priority? What is happening here in terms of this patient, in terms of the pathophysiology regarding opiate overdose? What is happening? So this patient is on morphine. The respiratory rate is 6. What is happening in terms of the pathophysiology behind? See, respiratory distress. Is this patient in respiratory? What is going on? It's respiratory depression, probable overdose. Toxicity. Okay, so yeah, the patient is getting too much of that narcotic. They're overly sedated. So the respiratory rate is depressed. So you want to go ahead and get your antidote. Yes, so your answer here is A, call rapid response team. B, administer naloxone. C, increase the oxygen to 6 liters per minute. Or D, stop the PCA and reassess in 10 minutes. My little California girl says B, administer naloxone. Nice. Yes. So you go ahead, more than likely we already call rapid response team. But what is the priority here? The priority is to get that respiratory rate corrected. And so you want to go ahead with your naloxone. So that is the priority. That is going to help with fixing that respiratory rate. So B. So I see here B or C. You have to choose one for your NCLEX. You can't choose two. So you have to choose one. So increase the oxygen to 6 liters. No, you don't want to increase the oxygen to... Never do C. Yes, so you don't want to do increase your oxygen there. You want to go ahead and administer naloxone to help with that. Stop the PCA. Yes, you're going to stop it. Reassess in 10 minutes and then reassess the patient. But the priority for this patient is to get that naloxone on for that patient. Hold on there. Okay. So let me pull this over. So why not C? So why not C? You're just going to be increasing the oxygen level for this patient. So it's not going to really fix the problem. It's not going to fix that problem with why the patient is having that respiratory depression. If you increase the oxygen, she won't have enough respirations to receive. Yeah, so you don't need to increase the oxygen. Eventually, you put the patient on a small amount of oxygen, but that is not something you'd want to go ahead and do. You want to go ahead and administer that naloxone and get that patient respiratory rate increase. And then remember that this patient is barely breathing, so increasing all of that, increasing the oxygen is just going to worsen the problem. Respiratory rate. So we'll go with B, administer your naloxone. Severe respiratory depression, opioid overdose. So you tend to use your naloxone, which is for your reversal agent for overdose on opioid. What's the priority? What's the priority? It's asking what is the nurse's priority. So what's the priority? The priority is to get that respiratory rate corrected. Okay. If it was asking what is the first action of the nurse, what would be the first action of the nurse for this question? So if it was asking what is the first action of the nurse, what is the first action of the nurse here? Jill says D, Sarah says D. So, okay. So stop the PCA would be the first action. Assess. Yes. So you want to go ahead. So make sure you're looking at the keywords that they're using. So this is what is the priority. The priority is to get this respiratory rate corrected. And with that, you're going to be using your naloxone. If it was asking what is the nurse's first action, the first action is to assess your patient. You would go ahead and stop the PCA. Reassess in 10 minutes would have been incorrect. You'd go ahead and assess your patient, and you assess and realize that this is happening. You will go ahead and administer medication, and then from there, D is wrong because of the second part. Yes. So we say that B is the answer. Go ahead and administer your naloxone as your first priority action. A patient with heart failure is receiving furosemide. What kind of drug is furosemide? What class of drug is furosemide? So nurse can't give anything without standing order. Loop diuretic. Yes, so it's a loop diuretic. Would this medication work with a patient that has intracranial hypertension? Is this something that would be effective for a patient with intracranial hypertension? Furosemide. Is it something that would be effective for a patient that has intracranial hypertension? No. Okay. Mannitol would be. Where does your furosemide work? In terms of the mechanism of action, where is your furosemide going to be working? In terms of pathophys, effective for hypertension, heart failure, PE, kidneys, yes. The loop of Henle. So anything like your, you know, CHFers, they can get it. Kidneys. 3 dots on a red car. Welcome. No, we already see a long time. Fluid overload people. Yes, Dr. Clem. I think pulmonary edema. And you have to watch your potassium. Yes, you have to watch your potassium. So you have a patient with heart failure that is receiving IV furosemide, which finding requires immediate intervention. A, pedal edema. B, irregular heart rhythm. Weight loss of 1 kilogram overnight. Or D, increased urine output. You see all of us saying B students. It's potassium wasting diuretic. Yes. So it's potassium wasting. So this patient is going to be at risk for irregular heart rhythm because of low potassium. So the patient is going to be at risk for hypokalemia. Yes, so diuretics can cause arrhythmias, potassium. Yes, they cause that. C can be I. So just think of the medication, what it does, and then from there you choose the one that requires immediate intervention. Yes, this patient has heart failure, so you're expecting that this patient is going to have some form of, you know, swelling. So that is not something that you need to intervene immediately for. Weight loss of 1 kilogram overnight. Yes, you know, that is pretty okay. You know, patient having a lot of fluid. More than likely the medication is working. Increase urine output, that is the effect for the medication. So you don't need to be concerned about that. The one that you'll be concerned about is the irregular heart rhythm, because we know that furosemide is potassium wasting. And so this patient will be losing potassium. So you want to keep an eye on the heart rhythm for any changes. In terms of ECG changes, what are you looking for on your EKG? What kind of, for your hypo? So for example, your patient is hypokalemic. Okay, I see Chances tall P waves. Peak T waves, lead innovation. Who is it? Peak T waves we'll be looking for? Low T waves. Yes, they're going to be inverted, the opposite of hyper, which would have been the tall T waves for your hyper. So they're going to be inverted low. Yes, so they're going to be low T wave. Hyper is peak. Or tall. Hypo is U wave. And so it's going to be the opposite of your... So hypo is U waves are inverted. Nice. So the answer is B, irregular heart rhythms. Your loop diuretics can cause potassium loss, resulting in dysrhythmias, sudden cardiac death. This is more dangerous than the fluid shift. So you're expecting that, you know, you're going to have your fluid shift in these patients with heart failure. So that is not like an emergency. A patient receiving norepinephrine has cool, pale fingers. What should the nurse do first? A, check the blood pressure. B, reposition the limb. C, increase the IV rate. Or D, stop the infusion. So the patient is receiving norepinephrine. The patient has cool, pale fingers. What should the nurse do first? D, stop the infusion. Why are you stopping the infusion? What are you thinking? So my little California says A, check the blood pressure. So D, yes. Nelly Belly, why are you stopping the infusion? I need more than toxicity, because vasoconstriction is impairing perfusion. Yes. So just think of the medication here, norepinephrine. It's a vasoconstrictor. It's a very, very, very potent drug here. So that can cause, you know, circulation problems. So if you realize that a patient is cool, pale, you want to go ahead and stop that infusion. So one thing you have to do with these patients, you have to keep on be looking at, you know, examining them, assessing them. So look at their ears, their toes, their fingers. You have extravasation that is going on because of that. So cool, pale fingers results in extravasation risk. Norepinephrine can cause tissue necrosis, so stop it immediately. Yes, we'll eventually check the blood pressure, or you should be checking that blood pressure very frequently. Reposition the limb. Increase the IV rate. No, you don't want to increase the IV rate because that is going to cause further problems with the extremity. You don't want anybody to have any amputated fingers or toes or limbs. So make sure you're watching, you're keeping an eye on your patient, documenting your rate for your drips appropriately, correctly. Because it's necrosis, because it's a vesicant, yes. Hello, welcome to the page. Thank you guys for tuning in. If you don't mind, go ahead and follow the page, share the live, and tap up the screen. That's all I'm asking. All right, so let's go on to this question here. A client is on an insulin drip for DKA and has potassium drop from 3.6 to 2.8. What is the nurse's best action? So DKA, what is DKA? A lot of times we tend to be saying it. What is DKA? What DKA stands for? Diabetic ketoacidosis, yes. What ABG imbalance is this patient at risk for or is in? So what metabolic or what ABG imbalance is this patient in? Coming from metabolic acidosis. Is it something that is consistent with type 2 diabetes or type 1 diabetes? So metabolic acidosis. Oops, it's me. I see you. How are you doing? So type 1. I see a few persons here says type 2. Which of the condition is associated with type 2? So DKA is associated with type 1. Which of the other is associated with your type 2? Your HHS? Yes. HHS is type 2. Megan, welcome. SIADH. Shano, how are you doing? So you have a patient here. So the patient had a potassium of 3.6 and now it is at 2.8. Why is this patient having? What is the pathophysiology behind, you know, or the mechanism of action as it relates to your insulin and potassium in DKA? What is happening? What is happening here? Why is this patient potassium is falling? Pushing potassium into the cell. Okay. What is pushing potassium? The blood, the fluid, the IV fluid, the acid. Which one is pushing? The insulin regular. Potassium is coming out of the cell. Yes, so your insulin. So always know the action behind the medications you're giving. So you have your patient that is on your insulin drip for your DKA. They have potassium that initially was at 3.6. It's now at 2.8. So the insulin is pushing that potassium. So hence why it's, you know, getting low. So what is the nurse's best action here? Is it to increase the insulin rate? B, continue insulin but add dextrose. C, hold the insulin. Or D, ask the provider for new orders. So insulin, regular insulin is the only insulin that could be pushed, IV push. Okay, yes. So C, you want to go ahead and hold the insulin. So now you go ahead and hold the insulin. What are you going to be doing? Are you going to be holding and looking at this patient or what? Are we going to sit down and have a conversation? What are you going to be doing for this patient? So this patient is in DKA. You hold the insulin. So in IV fluids and calcium, you're going to add your potassium. Yes. Megan, welcome. Miss Jerop says assess. Okay. So you're gonna get your EKG. You will go ahead and the patient should have been on the monitor, should have gotten a baseline EKG already, trying to get their potassium back up. Yes, you're gonna get their potassium back up, Tiara. So you're gonna get your order for your potassium. And okay, so Enrique is saying PO potassium. Is this patient someone that you will go ahead and do oral potassium on? Is this someone? So you have a patient in DKA, and we know that this patient is emergency. It's a medical emergency. Is oral potassium something that you would give, or IV? So yes, so IV potassium is what you'd want to give this patient. No oral medication around here right now. This patient needs the potassium in the system because of the risk for the arrhythmias. So this patient is at 2.8. So you need to get this potassium where it's supposed to be. So you hold the insulin and no push. Yes, Sparkle. No IV push potassium. We know what potassium will do. So no IV push potassium. You do your slow infusion for your potassium. Get them on the monitor, and then from there, you never push potassium any at all. So you're eventually gonna get your orders. Hopefully there should have been standing orders for this patient, because we already know the mechanism of action with your insulin. So there should have been an order. Riri. Riri says, I thought we push potassium. My teacher told me that. You know, you come to mix up the class, you know. But thank you for thank you for tuning in. But no, you don't push potassium. That patient is gonna be like, dead 6 feet under if you go ahead and push that patient potassium. So we're not putting any patient in any body bag. All right. So never push your potassium. And if it means that you're gonna double check with another nurse, regardless of how long you've been working. I always go ahead and just double check it. Not saying that I'm not confident, but there's certain medications I just don't play around with. So I always just have somebody just look at it and just, that's it. So you go ahead, you do your insulin. There should have been an order for your potassium replacement, because as I said, this patient is gonna be on an infusion. So you want to ensure that you always have potassium there while you're giving that insulin. So you'll go ahead and do that. What else would be a part of this patient's regime? So you know that this patient is at risk for arrhythmias. Potassium is low. We're doing DKA. We already have insulin on board. What else are you expecting in terms of the treatment for your DKA? Oxygen. So depending on what's going on for your patient. So what kind of respirations will this patient be having? Your DKA patients have a specific respiration. What is it called? Or the breathing? Cosmal, yes, your cosmal respiration. So calcium gluconate. Okay, yes, you could give your calcium gluconate for this patient. Why are you going to give your patient calcium gluconate? Who said that? Miss Jerop. Why would you give this patient calcium gluconate? So Queen D is asking, why wouldn't you increase the insulin rate? So just look at it. So as we say, if you understand the action of insulin, you would not want to increase this. You wouldn't want to increase the insulin here. So you would not increase the insulin. You'd hold the insulin, replace the potassium because the potassium is low. If you increase the insulin, your potassium is gonna, continue dropping, and then that is gonna result in your patient having arrhythmias. So don't increase your insulin, just hold your insulin, address this, this immediate emergency that is going on here with the potassium that is going further down. So yes, so you want to give the patient the calcium gluconate to help with stabilizing the patient's heart. So normal potassium is 3.5. Yes, so because of the risk for the arrhythmias, you'll go ahead and do the calcium gluconate. So yes, it's help with stabilizing. So you'll hold the insulin, and then once you get your potassium corrected, then you will give your insulin. So isn't calcium gluconate used in hyperkalemia? Yes, because of the risk for the arrhythmias, because of the high potassium. So the best action here will be your insulin. And then, you know, this patient will be getting a lot of fluids. Why would we be giving this patient a lot of fluids? Why is this patient going to be getting a lot of fluids? Why is this patient in DKA? Why are the patients in DKA always getting a lot of fluids? Lori, welcome, welcome. Yes, because of the risk for dehydration that is going on here. So you need to go ahead and resuscitate this patient with tons of fluid. So we say hold the insulin and replace the potassium. Insulin pushes potassium into the cell and can cause fatal arrhythmias. Never give potassium when your never give insulin when your potassium is less than 3.3. So let's go on to this patient. A patient with a chest tube for pneumothorax suddenly shows no tidalin in the water seal drainage. What is tidalin? What is tidalin as it relates to chest, your chest tube? What is that? What is tidalin? Let's see, air escape. Yes, 3 dots on a red car, rise and fall. So yes, the movement, the up and down movement of the chest wall. So you're looking at the fluid, the rise and fall. You're looking at the fluid, you know, in the chest tube drainage, the water seal chamber there. So it should be like moving in such a way where it looks like, you know, like waves in a sense. Yeah. So you have a patient here with chest tube for pneumothorax who suddenly shows no tidalin in the water seal chamber. What should the nurse check? A, the color of the drainage. B, the tubing for kinks. C, the suction pressure. Or D, the patient's oxygen saturation. I see B, Leon the roaring baby, welcome, says the patient's oxygen saturations. So Bailey says C. Oh no, says kinks. So what should the nurse check first? So think of it, you're gonna still do your assessment. Start with assessing the patient. So Foxcroft, how are you doing? So is it the color of the drainage? No. The tubing for kinks, we'll put a tick beside that one. The suction pressure, the patient's oxygenation saturation. So D and A we're gonna say is out of it. The tubing for kinks, the suction pressure, which of them are you gonna be looking at? I will say B. Look at B, because if the tubing is kink, you're not gonna have that flow. So you want to assess your patient. You're not going to see the change. You're not going to have that tidalin that you're expecting with your chest tube. So if it is kink, if it is obstructed and there is no flow, no air flowing in, then you're not going to have that tidalin going on. So the most common cause is the kink being obstructed. What's the difference between picking B and D? So picking B and D, the tubes for kink or the patient's oxygen saturation. So what should the nurse check first? So when you check the patient's oxygenation, and say for example, you get 70%. Yeah, oxygen is assessment as well, Miss Lady, but just think of it. Make sure whatever you're assessing for, the answers that you're choosing, it makes sense to the scenario. Because what should you do? You're gonna check the oxygen saturation. Is that gonna fix the problem there or tell you why the patient is not having that tidalin? The sat is 70%. Is that gonna change anything? If you look and you realize that the tubing is kink, go ahead and check the tubing first, because that is where the problem is. There is no flow, so check that system there, the equipment, to make sure it's working first, because that is what the problem is. Check the tubing. Yes. You'll eventually check the oxygen, but just make sure you're thinking about what is happening with the patient and the scenario that they present. So always assess the equipment before assuming clinical changes. So a patient receiving IV vancomycin. What is IV vancomycin? Is that like a beta blocker? What class of drug is this? Is it a beta blocker? Is it an antihypertensive? Is it a... oh, Brittany says antibiotic. Nice. So it's an antibiotic. All right. This patient develops flushing, itching, and hypotension. Aminoglycoside. Jerry, welcome. Thank you for that. So it is, you have a patient that is developing flushing, itching, and hypotension. What is the most likely cause for this? So you have a patient that is on IV vancomycin developing flushing, itching, and hypotension. What is the most likely cause? See here, Miss Lady says Redman syndrome. Sarah says B. Nasir says A. Okay, so B. Dorian Perks, welcome. Redman, okay. So a lot of persons are saying Redman. Lulu, why did you say A, anaphylaxis? So don't exceed your IV over 60. It will not be because anaphylaxis only deal with airway. Yes, who was that again? Nurse T32. It's an adverse reaction. So it's Redman syndrome because of this medication here. And then just make sure that when you're looking at it, try to see, okay, then if you see Redman syndrome and you think that Redman syndrome is associated with vancomycin, they put the antibiotic name there for a reason. As I say, remember that NCLEX is testing you for safety. That is what they're thinking. They're always thinking about safety of the patient, safety of the nurse, everybody else in the room. So always look at it and see. So they put the vancomycin there for a reason. If they never had this there, and you probably had flushing, itching, a patient receiving a medication, they probably never said it, and you had the patient developing flushing, itching, hypotension, probably having swelling, then you could go with your anaphylaxis. But if they have vancomycin there, think about what are some of the things that, can result from the medication that they have in the scenario. And then from there, you'll choose it. They mostly give the antibiotics to someone who has C. diff. The process of elimination. Yes, and use the process of elimination as per K-POW here as well. No, but it's also a black box warning. So just look at it and then from there. So what do you need to check prior to giving your vancomycin? So as I say, NCLEX is going to ask you about safety when it comes on to certain things, such as your medication. What is one thing that you need to do? So apart from allergies, that is right across the board for everybody, not only for medication, but also for food. Apart from allergies, what is very important for you to check before giving a patient on any form of vancomycin? Jerry says kidney function. I want the specific kidney function that we're looking for. May I pretend like me not see you? Oops, it's me. So let me see. Creative Ashcash, I think you're saying creatinine. Lopez Samuelito, yes. So now, yes, so your creatinine. I see Shan says BUN. BUN, most of the time will tell with your dehydration. But the one that is going to be very specific that you need to look at for your vancomycin is the creatinine. Because of what? Your creatinine. Creatinine is specific for your vancomycin because of what? Nephrotoxicity. Liver toxicity. Okay, but nephro specifically for your kidneys. So because of the effects it has on your kidneys. So if you realize that you're scanning through your medication or your labs and you realize that the creatinine is a little bit elevated, let your doctor be aware. Say, hey doc, you know, this is happening. Can we, you know, use something else because of the fact that you see changes in the creatinine for this patient? Don't go ahead and just hang it, and just make sure you document as well. Work not documented is work not done. Renal function. Calm down, says D. Histamine block? No. Calm down. Tiara. The answer is Redman syndrome. Oh, you're telling me. So Redman syndrome, rapid infusion. You have the histamine release there. So you have flushing, itching, and hypotension. So you want to go ahead and slow the rate for this patient. It's not an allergy. It's just an adverse reaction to this medication. So once you slow the rate down, a lot of times the patient will have improvement in the symptoms. So 1 hour rate, nice, yes. So a COPD patient on 4 liters of oxygen suddenly becomes confused and drowsy. What is happening with this patient? So you have a patient that is COPD, is now confused and drowsy. The patient is on oxygen. What is that? What is happening with this patient? Okay, so CO2 retention, you're telling me without even saying it. So yes, your CO2 retention. So what is the priority concern? So we have hypercapnia. You want to lower the dose. Oxygen toxicity. So too much oxygen can suppress their hypoxic drive, leading to CO2 narcosis and alter their mental status. They shouldn't have more than 2 liters. Nice. Okay. It's bedtime for you, Zarian. A new tracheostomy. Patient coughs violently and the inner cannula falls out. The outer cannula stays in place. What should the nurse do first? A, call for help. B, cover the stoma with a gauze. C, insert the clean or a clean inner cannula. Or D, begin manual ventilation. See B, B, C. Let's see 1C, 2C. Keisha, welcome, welcome. Nurse T32. C, all right. So if you cover, they will suffocate. Christian, nice. So go through with the process of elimination. So what should you do first? Call for help, cover the stoma with the gauze, insert a clean inner cannula, or begin manual ventilation. So gonna go ahead and insert a clean, because so it says here that the inner cannula falls out, the outer cannula stays in place. So the airway is still secure, right? Christian, reestablish airway. So the inner cannula falls out, the outer cannula stays in place. I absolutely cannot believe I said to cover it with three dots on a red card. Okay, so insert a new inner cannula. Airway is still intact, so simply replace the inner cannula to reestablish airflow. So that's the answer for that one. Begin manual ventilation. That's not needed for this patient. Insert cover the stoma with the gauze. As we said, it will suffocate the patient. And then call for help. You know, depending on you, you can decide if you want to. I know sometimes we call for help for everything. So, but what you would do first is basically to just reestablish the airway. And more than likely, if you're, you know, it's always recommended you have a patient with a trach. Always have a trach kit at the bedside. So you have extra supplies at your bedside. So when you go in and see a patient and they say, oh, or you notice that they have a trach, just scan the room and look for your trach set. If you don't have one there, you go and get one and put it at your bedside for emergencies like these. So if the patient cough it out, you can always have a clean one readily available to put back in. So you won't be running around the entire department and calling all over the, you know, the hospital trying to find a trach kit. A patient with suspected meningitis What kind of airborne precaution is this patient on? Patient that is on has suspected meningitis. What airborne what precaution is this patient on? Suspected meningitis, airborne precaution, contact. So droplet, yes. So droplet precautions, this patient would be on for your meningitis. Raining men, so droplet. Okay, Christian, nice way. So this patient is going to be on droplet precaution. So this patient suddenly develops hypotension or becomes hypotensive with cold extremities. What complications should the nurse suspect? A, neurogenic shock, B, septic shock, C, anaphylactic shock, or D, cardiogenic shock. So you have a patient that has suspected meningitis. They are now hypotensive with cold extremities. What complications should the nurse expect? A, D. Okay, all right. Who says B? I think this is Giselle. J3Z3LL, fancy word. Okay, so all right. So Denisha says septic. Septic. Okay, so I see a few persons that say septic. So we're gonna go with B. Gabrielle says B. So what is meningitis? Sepsis shuffles perfusion inwards. Hannah Rose, welcome. I think it's A. I think it's B. So meningitis can rapidly progress to sepsis. Hypotension and tachycardia and cold extremities are classic shock signs. Let's go through the the shocks here. So yes, Tiara, it's inflammation of the brain, meningitis there. So infection of the meningeal covering of the brain and the spinal cord. Yes. The meninges. I see you, Ken. Welcome. Oh, too edgy for you. Welcome. I hope that's a good sound or a good thing to say. But the patient became hypo with cold extremities. So let's just go through the different. For neurogenic shock, what are you expecting for neurogenic shock? Okay, nice, too edgy for you. Okay, so for your neurogenic shock, what are you expecting for neurogenic shock in terms of the pathophysiology? Warm and dry skin. They're bradycardic, confused. Most of the time, the shocks eventually will become confused. Hypotension, bradycardia. Yes. So with this patient, neurogenic shock, what are some of the causes for neurogenic shock? So probably that's what I should have asked. What are some of the causes for a neurogenic shock? And once you understand the pathophysiology behind each of the shock, then you'll be able to tell which shock is associated with which condition. So yes, any form of trauma, brain injury, spine injury, MVCs, AMS, TBI, yes. Medications, things like those can cause it. So they have like the loss of the sympathetic tone resulting in there. So they tend to become like bradycardic, hypotensive, warm, dry skin. So know that one. So your neurogenic shock. So is this patient in neurogenic shock? Use the process of elimination and answer. We're going to put an X beside it. Let's go down to anaphylactic shock. Does anything in the scenario here gives you the indication that it is an anaphylactic shock? What are some of the causes for anaphylactic shock? Can hyponatremia cause neurogenic shock? Oh. I'm not thinking along that line. Who was it? three dots and a red car, but I'll look it up. Allergies, hypersensitivity. Yes. And then for cardiogenic shock, what are some causes? Think about the pathophysiology behind it. Overload, endocarditis, any form of obstruction, cardiac tamponade. So just think of it that the heart is failing. So the heart fails as a pump itself, and so that's how you have cardiogenic shock taking place. So they becomes like hypotensive, they'll become tachycardic, they'll have the jugular vein distension. Your extremities are going to be cool, crackles, edema, yes. So that is what is going to be associated with your cardiogenic shock. So it wouldn't be neurogenic because it says nothing about trauma in the question. It doesn't have to really say trauma in the question, but just think about the pathophysiology behind each of the condition and the different shock. And then from there you can choose. Because even though you're probably thinking that, oh, the patient having the symptoms, or, you know, the patient is hypotensive, they're having the cool extremity, would neurogenic shock be really something you'd think about for your patient who is suspected for meningitis if you have the option for septic shock there? Remember, the meningitis is caused by an infection. So the one that is going to be most related to it would be septic shock. Just like when we were talking about your hemorrhage patient. If you have the option to choose between hypovolemia, I know somebody that says hemorrhagic, then you'll go with your hypovolemia because they're losing blood. Sure. So that's why I say if you don't understand your pathophysiology, that is where the problem is gonna be. You have to understand pathophysiology, and then if you understand pathophysiology, you understand mechanism of action for your medications, and you can put two and two together and realize that it's still two. So it's very, very important for you to understand your pathophysiology. So then we go on to septic shock. And, you know, we say that septic shock is caused by an infection, which we know that the patient with meningitis is caused, you know, is having an infection there. So that is the one that is going to be most likely related to, as be a complication of that. So it progresses to sepsis. So hypertension, tachycardia, cold extremities are classic shock signs. So all of them are, you know, the symptoms there, the signs and symptoms are for your shock. But at the end of the day, choose the one that is related to. So we know that meningitis is for because of an infection. Choose the answer that is related to an infection, because all the signs and symptoms they're giving you is related to your shock patients. So, okay. All right, let's try and tap up the live. Let's see if we can get this live up to 8,000. And remember to go ahead and share if you haven't followed us yet. I would love for you to go ahead and follow the page here. If you're tuning in late, the live streams that I do, they're all posted on my YouTube page. So go over there and subscribe to the YouTube channel. I post other contents over there as well that will benefit you as a nurse, international nurse, things like that. So go over there and check out the page and be a part of the family. I feel like nursing is not that hard. You gotta just understand what the question is asking. Yes, you just have to understand what the question is asking, and then from there. And it's the same thing for your NCLEX. As I say, just think about safety. Ask yourself, okay then, if I don't do this for the patient, what is the worst thing that can happen for the patient? And once you're using your airway, breathing, circulation, you're using your ADPI, assessment, diagnosis, planning, implementation, evaluation. Once you're using your Maslow's hierarchy of needs and you're looking through the question, you know, to see, is this a ABC problem? Is this a Maslow problem? Is this a ADPI, the nursing process problem? Once you're able to identify that, you think of, okay then, what is the safety problem here going on? You do that, you should be able to do well with the question. Just don't rush the questions. I just got my ATT this morning and scheduled my NCLEX. Congratulations, T-Lore. Congratulations. So what would kill the patient first? So which one would kill the patient first? So it depends on what is going on with the patient. It depends on what is going on with the patient. So for this patient with meningitis, we know that this patient has infection on board, so septic shock is gonna definitely kill the patient first. If it is a case where they say that this sepsis patient got, let's say, oh yes, Miss Lady, in general, just think of it that, okay, you have your patient in front of you. What is it that you need to do now? What is the most important thing? And then from there. So it is 8:25. I know we had some more questions, but you know, I have to go look good. I have to go finish up my hairstyle. I have to go and finish up my hairstyle. So I will see you guys. Let me turn around the camera so I can see the hairstyle. I'm gonna finish up. You're welcome, Riri. I'm gonna finish up my braids. I'm trying to put my faux locks in, so I'm doing the 3-strand plait, and then I'm gonna wrap them. So by next week I should be finished. Oh, Miss Lady, you have finals. Okay, Flora, thank you so much for tuning in. Thank you so much for tuning in. Thank you, Giselle. Not a problem. 3 dots on a red car. Oh, Sarah, because I have to finish up my hair, I'm going to do my and I have some charts to do, and then from there. Thought you were Filipino because of your accent. No, Kachiri, I am from Jamaica. Thank you, Monex. Yeah, I want the live stream to be very interactive because I know sometimes we just need extra motivation to study, and we might be studying and you feel bored sometimes. So when you have persons coming together and we can do things like that, I feel as though we cover more and persons will be able to stay up a little bit longer. Nurse T32 is asking who wants to study with me. Chrissy, yes. So I did sign up for the U World, but I'm trying to get the subscription on another account. So with that, I have I will be doing like some small groups because some persons were asking about one-on-one. I can't do the one-to-one right now, but I can do small groups and we go through like, you know, the U World questions, and Kachuri we'll do some small group U World questions, and then from there. Oh, you just got the NCLEX boot camp? Okay, okay. Yes, so yesterday we tried some of it, but then I only did 10 questions yesterday. So I did got my refund. Well, it's not back in the account as yet, but I don't want to spend so much money and it's not back in my account yet. So I'm waiting for it to be in my account, and then from there I will do that. So I have some small groups that I will be. You can inbox me regarding them, and then we can try to meet on via Zoom and go through a few questions. So we'll try to do, what I'm doing is I'll try to have like once a week where we can go through a few questions. So probably like 4 hours worth of questions from U World. And hopefully that will help for persons that are going to be sitting their exam soon. So we'll go through just the U World questions and then from there. So let me know if it is something that you are interested in. Inbox me and then we can talk about it a little bit more. Hi Chang, you're just coming in. Oh, my next class is gonna be on Thursday. So on Thursdays usually we'll go a little bit longer just because I'm not working. Because I'm not working in the morning. So I'll tend to spend a little bit longer on Thursdays. Let's get this license before end of year. Flora, welcome. Do you do pediatric questions? Yes, I did some pediatric questions in some of the live streams. As I say, on YouTube, Go onto YouTube and you'll find some questions that we've done before. We've done pathophysiology questions, cardiology, GI, endocrine, renal, musculoskeletal. So the channel is ThinkNursing. It's one word. Just go over there and subscribe and watch the videos as they go through throughout the day. So yes, it's the same name on YouTube. You go there and look at that. But there are tons of videos over on YouTube that I've posted that we've been doing on the live stream here. So you will find them in a playlist that I created with only the live streams for YouTube, for NCLEX questions. There are other questions over there, but yeah. So yeah, so there are 19 videos over there with like questions. So, oh, you guys on YouTube already see it. So go onto YouTube and look at them. So GI, cardiovascular, and some of the videos are like 4 hours. Because sometimes we'll be here and it is so much fun. I'm enjoying the live streams. I'm not lying. I'm learning and you guys are learning and it is fun. So, yeah. So GI, we do a mixture of questions. I think the ones that we were going to do, the ones that I had. All right. I'll go until, let's see. I'm going to go until 9, not 9 o'clock. I'm going to do 15 more questions. Who is asking? Oh, yes. I'm going to do 15 more questions. 8:30. Yeah. Kashuri, let me do about, because I had, I think this section was, what question was it? So I will select the all that apply question. These are some things that we already went through, but ThinkNursing, it's the same as my handle here. So it's the same as my handle here. So you can go ahead and just look at that and subscribe to that page. So, all right, let me do until 8:45. So we'll go back over here. Not a problem, Flora, not a problem. So I'll go until 8:45. Oh, I forgot my son. We'll go until 8:45. So which interventions are priority for a patient with DKA? We did talk about this in detail earlier. Select all that apply. A, start IV normal saline. B, give IV regular insulin. C, and as I say, when it comes on to your priority questions or you select all that apply questions, treat each answer as a true or false. If you're able to do that, you go through. Start IV normal saline. Is that something that you would do for DKA patient? And think about the pathophysiology. Think about what is happening. Is that something you'll do? If it is, then you select it. So start your IV normal saline. Give your IV regular insulin. Administer IV potassium after verifying urine output. C, give sodium bicarbonate immediately. E, monitor EKG continuously. Or F, restrict fluids. So we'll start your normal saline, A. B, give your regular insulin. Administer IV potassium after verifying urine output. Is that something that, for this part is like, you know, for me. But give sodium bicarbonate immediately. You know, remember that this patient is in DKA, so patient is in acidosis, so you'd need some bicarb. So I would say I'd keep that one. Monitor EKG continuously. Is that true or false? Yes. Restrict fluids. We know that this patient needs the fluids, so we ain't gonna restrict anything. So we'll go ahead with A, B, C. Okay, so A, B, C, E. So, oh, there's a D. All right. So the priority for the patient. Okay, so remember the priority for the patient. Fluid resuscitation, insulin, potassium. I know a lot of times we might be doing certain things, but not all of those are priority in NCLEX world. So we'll definitely do the fluid resuscitation first to correct the dehydration. Give your regular insulin to reduce the blood glucose and the ketones. So even though you're in the 200s with your glucose and you're thinking that, oh, you should be stopping your insulin, you're trying to correct the ketosis, or you're trying to correct that acid-base imbalance. So you will go ahead with your dextrose water and continue your insulin until the patient is ketone free or the anion gap or the gap is closed. So even though the insulin is, you know, the glucose check is going down and it's like in the 200s, 250, you wouldn't stop your insulin. You'd go ahead and give your dextrose and continue with your insulin treatment to help with getting rid of that ketone. Then potassium may drop quickly once insulin started, so you must replace it if it is needed and urine output is adequate. High potassium or low potassium results in arrhythmia, so you want to continue with your EKG for this patient. Bicarbonate, not routine unless severe acidosis is present where the pH is less than 6.9. So that's what I was saying. A lot of times we might see patients be getting it because, you know, they're acidotic, but unless it is below 6.9 in terms of the pH, then it is recommended. So it is not a priority for this patient. So in NCLEX world, not everything that we're doing in the real world is going to be appropriate in NCLEX world. So the answer is A, B, C, E. Start your normal saline, give your regular insulin, administer your IV potassium after verifying your urine output, and then E, monitor your EKG continuously. The next one is the patient, the RN is caring for a patient with acute decompensated heart failure. Which actions are appropriate? Select all that apply. A, elevate the head of the bed. B, administer IV furosemide. C, give 2 liters of fluid bolus. D, apply oxygen if SAT is less than 92%. E, weigh the patient daily. Or F, place the patient in high Fowler's position. So you have a patient that is in decompensated heart failure. Which action is appropriate for this patient? Elevate the head of the bed for the patient. Is that appropriate? Yes. Because this patient has too much fluid on board. So you put this patient to lie down, they're going to be suffocating because of all of that fluid. Administer IV furosemide. Definitely this patient could benefit from getting some of that fluid off with your furosemide. Give 2 liters of fluid bolus. No, you'll be drowning this patient. So we'll eliminate that one. D, apply oxygen if the SAT is low. Less than 92, that's fine. Weigh the patient daily. Place the patient in high Fowler's position. So we'll say everything there except C. Let's see, A, B. Okay. So A and F, upright position improves lung expansion. B, the diuretics remove excess fluid. That is going to be first line. D, oxygen restores perfusion. E, weight monitoring tracks your fluid. No, F is included. Everything including F except C. Amora, welcome. So never give fluid bolus to your heart failure patients. This worsens their overload. So everything except C. So the answers, those are the answers. So everything included except C. Which order should the nurse implement first for an acute asthma exacerbation patient? Select all that apply. A, give short-acting beta agonist. B, administer inhaled corticosteroids. C, apply oxygen to maintain saturation of 94%. D, start IV normal saline bolus. E, assess breath sounds and work of breathing. Or F, place the patient in high Fowler's position. So you have a patient that is asthmatic. They're having acute exacerbation. Select all that apply. So we say give short-acting beta agonist. So you think about like your albuterol, definitely. Administer your inhaled corticosteroids. You want to apply oxygen. Start IV normal saline bolus. Is that something that you would need? No. E, assess breath sounds and work of breathing. Okay, place the patient in high Fowler's position. So we'll say we see ACEF. So albuterol, your bronchodilator. C, oxygen as needed for hypoxia. E, assessment before and after treatment is critical. F, positioning opens the airway. B, the steroids will help, but it's not the first intervention because the patient needs that bronchodilator. So that is the first intervention for this patient. D, IV fluids not used unless dehydrated. So let's look back at the answers. So we have, which should the nurse implement first? So you want to have your short-acting beta agonist. You want to do your oxygen, your breath sounds assessment, and placing the patient in the high Fowler's position. Tidon, welcome. And then we'll do this one. A patient with possible sepsis arrives in the emergency department. Oh, yes, it was there, Ijang. It's just that it wasn't in caps lock. So I don't know if that throws you off a little bit. So a patient with possible sepsis arrives in the emergency department. What are priority actions for this patient? So priority action, what is it for this patient? You have a patient with sepsis. A, obtain blood cultures. B, start broad spectrum IV antibiotics. C, begin fluid resuscitation. D, wait for labs before starting antibiotics. Or E, monitor lactate level. So what are the priority actions? All except D. You see A, B, C, E. Okay, so we definitely want to get your blood cultures. We will start the IV antibiotics. Begin fluid resuscitation. Wait for labs. You don't need to wait for labs before giving antibiotics. The patient needs antibiotics, so whether or not you get blood work, go ahead. At least try to get your blood, and then from there. If you can't get it, then don't slow down the process. Kristen says activate code sepsis, definitely. Monitor lactate level. See another one here, sorry. Maintain your map of 65, greater than 65. So the answers are going to be your A, B, C, everything except D. F2, yes, Sarah. So you must draw your blood cultures before antibiotics. Early antibiotics saves life. The patient needs fluids for, perfusion. Lactate guides the severity. So you get your initial lactate, and then you get your repeat on your lactate. So see how you're doing in terms of with the management. And the target for your map is 65 or greater to maintain, organ perfusion. So let's go back. So the patient with possible sepsis, here it is. So, okay. So when there's sepsis, start antibiotics. You're thinking about your antibiotics, but you want to get your blood cultures. Try and get your cultures. If you're having difficulty with obtaining your blood cultures, then you go ahead with getting that antibiotics on board. But make sure you try to get your blood cultures. If it is a case where you start your antibiotics because you're having difficulty with getting the blood, just mark on your labels that, this antibiotic was given. Vancomycin was given, Rocephin was given. So at least the lab will be aware that these medications are on board. So welcome, Tripped Metal Detector. Congratulations. You can go onto my YouTube page and subscribe. I talk a lot about nursing over there. So okay, so when the sepsis start antibiotics after you draw cultures, yeah, just don't wait around too long for your cultures if you're not able to get the blood. So what would you say the NCLEX would want us to do? Start. It depends on what the answers are on